Your story is an important segue to our first panel, which will discuss how to integrate detection of these disorders into medical settings like the obstetric setting. I'd now like to welcome Chris Botts to the stage. Chris will be sharing an overview of the work that he's leading at the American Medical Association. Then he'll be inviting several panelists to the stage to join him to discuss barriers and opportunities surrounding integrating mental health and maternal mental health screening and intervention into the medical home, including the obstetric medical home. Welcome to the main stage, Chris.
Thank you so much, Joy, and thank you so much everybody for having me here today. I'm just thrilled to be part of this important conversation. I think I should be seeing slides, but I'm not seeing them.
One moment, they'll be up in a moment.
Not a problem. Well, as I wait for the final slide, this first panel is entitled Mental Health Screening and Integration in Primary Obstetric Care. Perfect. Next slide, please. And today's specific objective is to address universal interest in providing behavioral health screening in primary care settings, barriers and solutions to adoption of screening, the need for system change to fully integrate behavioral health care into obstetric medical homes, and follow a no wrong door approach to supporting screenings in other settings. Next slide. I think everybody at this conference is aware of the mental and behavioral health crisis that's going on in our country, the fact that it's existed for quite a long time, and it's only been exacerbated due to the COVID-19 pandemic over the past several years. I'm not going to go into all the statistics that are captured here, but I think just the starkness of the issues around access, treatment, and particularly how that is relevant for the maternal health space, I think is really critically important to keep in mind as we go through our conversation today. Next slide. One way that has been identified to be able to address this drastic need is integrating behavioral mental health care within primary care settings. And this is really critical for multiple different points, one of which is much of mental and behavioral health care happens within the primary care setting, and that's only increased as the COVID-19 pandemic has persisted. It's also important to note that patients also are asking for better integration of these types of services, primarily within the primary care setting. And so as we think about moving forward, this is a really great stepping stone to be able to look at how to address that broad mental health crisis that's been going on. Next slide. In terms of integrative models, there's a number of different approaches that physician practices across the country are taking in this specific space. I'm not going to go into some of the specifics as there's a lot of kind of nuances, but I think the important part is practices across the country are working off of their existing resources and the needs of their patients to be able to create models that best supports the care team and the patients that they're serving. And so this spectrum of models that's out there makes it also challenging about how to use some of the levers throughout the different healthcare system in order to be able to better enable integration. Next slide. There's also a number of persistent barriers that have existed and again have been exacerbated due to the pandemic, one of which, and I think I might have heard a little bit about it before, but there's obviously a workforce shortage primarily within mental and behavioral health professionals. There's also challenges that practices have both in terms of creating systems in place and workflows in place that best meet, again, their current practice setting, as well as their patient needs. There's also issues in terms of just communication and facilitating data exchange between the various different members of this integrative care team. And then financial pressures that practices feel that often are put in choices about doing what's best for their patients and how to best sustain their practices, which is obviously not a position that we want to put anybody in. Next slide. There's also been a plethora of technology that's just exploded, especially these last couple of years. And that there are a lot of opportunities within that specific, that type of technology in order to be able to better enhance patient management, treatment, limit fragmentation, and generate value, particularly for patients and the clinicians that are serving them. It's also important to note there are limitations to this technology as well. Most importantly is that this technology should be augmenting the clinician-patient relationship and should not be replacing the need for in-person care when needed. There's also a lack of just economic evidence for many of these solutions that needs to be addressed to better support major regulatory and coverage decisions that are going on around the country. It's also important to note that certain technologies may not be clinically appropriate for all people, nor is technology the preference for all people or providers that are providing care. And it's important to keep those in mind as we figure out a sustainable pathway about how to move forward in this specific space. Next slide. And with all of that in mind, 8 of the nation's leading physician organizations have come together to create what we have called the BHI Collaborative, really focusing on the fact that there really needs to be a more cohesive effort, at least within the House of Medicine, to push forward this type of integrative care. Next slide. And these groups have come together with the sole mission of catalyzing effective and sustainable integration of behavioral mental health services within physician practices, with an initial focus on primary care, allowing these practices to, at minimum, identify and manage the mild to moderate conditions as a core part of their primary care practice, rather than the exception, which unfortunately is the standard across the country to date. And the collaborative is doing this through a number of different activities, ranging from educational programming to releasing resources to testing additional solutions, and ultimately working across various different stakeholder groups to, again, ensure that this type of integrative care can be sustained for practices and ultimately the patients that they're working to serve. Next slide. The AMA is also working tremendously within the broader maternal health space to do things like expanding Medicaid and CHIP coverage for 12 months postpartum and implement equitable standardized data collection methods. And there's a link here on the slide that people can look to see more of the work that we're doing in this space. Next slide. But that's enough from me. I think that I'm going to ask the rest of the panelists to join. I'm really thrilled to be joined today by a number of just fantastic experts in this space to be able to help really dive deeper into this important topic area. Let's start with Blair, if you could just briefly introduce yourself to the audience.
Thank you so much, Chris. Hi, my name is Blair Dudley, and I lead the Transform Maternity Care Program at the Purchaser Business Group on Health. PBGH is a coalition of self-insured purchasers, so both public and private employers, who collaborate to improve the healthcare system. And we have, I'm glad to say, over the last couple of years, we have really made a lot of great strides in engaging and educating our members on the importance of maternal mental health. The fact that maternal mental health issues are common, that often they go untreated, and that the societal costs are really quite huge, of course, to the individual, but also to the rest of our society and to the purchaser themselves. So we've talked a lot with our members about the challenges around screening and treatment, and really around what does screening mean, what does treatment mean, and we have developed a couple of strategies for how these purchasers, how these employers can promote maternal mental health and how they can impact their maternity marketplace to make for a better, not only a better quality of maternity care in general, but a better experience that includes and integrates behavioral and mental health.
Fantastic.
Chris, I'm going back to you.
Perfect. Jennifer?
everyone. So my name is Jennifer Torres. I am from Unified Women's Healthcare as a care manager for New York market known as Square Care Medical Group. I provide community resources to our care centers that they can share with their patients and help gear our patients in the right direction if they need additional assistance other than the services our providers offer them. I also care manage patients that are high risk who are in need of additional assistance and support. And I help patients connect with the appropriate resources, which ultimately benefit their quality of life.
Excellent. Welcome, Jennifer. And Dr. Zoll.
Thanks very much, Chris, and good to see everyone. Thank you for the opportunity to be part of the panel. I'm Chris Zahn. My title actually just changed within the last week or two, so it's the Chief of Clinical Practice and Health Equity and Quality here at ACOG. Our division is primarily responsible for production of clinical guidance, and certainly mental health and maternal mental health is a key component of that, but organizationally, we're involved at multiple levels with advocacy work by our government relations team. The clinical guidance is mentioned, as well as patient and clinician education around maternal mental health. And we have a number of resources to address that. In addition, we actually have a maternal mental health expert work group that consists of subject matter experts in maternity care, as well as in some cases psychiatry and behavioral health, and we're working on creating resources to help our members first to screen patients, but also connect them to the most appropriate help that they need. Thank you.
Thanks so much. We're excited that ACOG was one of the founding members for the collaborative, and I've worked closely with you all on our efforts. Dr. Kudum.
Hi, thank you, Chris. Thank you so much for this opportunity. I'm excited to be able to talk about a topic I'm so passionate about. My name is Dr. Nalima Kunum, MD. I'm a board-certified psychiatrist and the medical director for a large psychiatric medical group in Southern California. We're a little unique in the sense that though we have a traditional psychiatric clinic, of the 18 locations we have, 1/3 of them has a primary care next door. So we really are trying to implement and carry through the collaborative care, from the get-go. And so I'm excited to be able to give a perspective of, an everyday psychiatrist.
Excellent. Well, looking forward to learning a little bit more. And lastly, but not least, Dr. Wildenhouse.
Hi, Chris. Hi, everyone. Nice to be here. I appreciate the opportunity. I'm the Director of Behavioral Science for an innovative group within Johnson & Johnson known as the World Without Disease Accelerator and the Lung Cancer Initiative. The primary focus of WWDA is to move us from a very traditional model of disease care, where we wait for people to get sick, we diagnose, and then we treat them, to a proactive model of true healthcare, where we learn who's at high risk, and then we predict their pattern, and we preempt the disease with the goal of either preventing it or mitigating it. And my focus and work in that space has been around perinatal depression, so I'm really excited to be here. Nice to meet you all.
Excellent. Well, thank you so much, everybody. Just really thrilled that you all were able to join today. So just to start things off a little bit, first with you, Dr. Zahn. In your role with the American College of Obstetrics and Gynecology, what have you been hearing as the top 2 to 3 biggest struggles for obstetricians implement screening, as well as just integration more broadly in their practices?
Well, thank you, Chris. I think, first of all, the slide that you showed during your presentation with the barriers kind of summarized many of the most significant barriers I think our members face and most obstetric clinicians face as well. This is maybe a controversial statement, but we had a very interesting observation by our Committee on Ethics that met a couple of weeks ago, and it wasn't talking about mental health screening, but just screening in general. And the comment was, screening without the ability to follow up could arguably be unethical. And I thought it was a really fascinating observation, but it really rung home on the challenges we have with this issue, Screening is unquestionably important. We recommend it in our clinical guidance. We know that many clinician groups do. And I think we're moving the needle on screening. But the biggest challenge is, what do you do when someone screens positive? And you can almost envision a fear by the clinician and hoping to God that it doesn't come back positive, because then it becomes, well, now what do I do? And one of the challenges, and I think a fallacy or an opinion that we undo, is there's an oversimplified thought by some that it's fine if they screen positive, all they need is a prescription for an SSRI and you're good to go. And that is clearly not the case. While it might be for some patients, it is definitely not the most appropriate approach for the majority of patients. And the majority of the patients require some type of behavioral health interventions, potentially social work support, some combination to address the issue. So the simple give the patient a prescription is really not the right approach. However, the obstetric clinicians are really not resourced generally to provide that sort of help. They may not have the background education depending on their education and practice setting, and they may not be aware of resources to connect those patients to the most appropriate health care that they need. So I think the real barrier, or the biggest barrier, is the network in place, is the system in place to plug those patients in to get them the referral and the care that they need. So to me, that's one of the really significant aspects. Is there the capacity within the practice to do that? So even if the system does exist and the referral network is in place, do they have the capacity in their practice, realizing practices can range from single person practices to full-on academic environments? Do they have the system in place and the capacity to do that sort of screening and the follow-up to get the patient plugged in and ensure that the care is followed up? Certainly, and I think there was some discussion in the lead-in session about reimbursement. We ask our clinicians to do a lot of things. Not everything is fully reimbursable. So I think it's a burden on clinicians across the board to ask them to do additional care for which they may not be reimbursed, particularly if it involves additional time or additional visits. And I think another significant aspect in this whole consideration are the social and structural determinants. Even if you can screen, even if you can plug the system or plug a patient into an existing system, what are the social and structural determinants and the barriers in place that are going to make it difficult for that patient to show up? For example, if you do have the ability, realizing that the resources are limited for behavioral health, what if that patient doesn't have transportation? They can't get into that appointment. Or what if they're a single mom and they've got a couple of children, including a newborn infant, if it's in the postpartum setting, and they have to find childcare, transportation to be able to try to get to an appointment. So there are some significant challenges, even if the system is in place, to try to get that patient into the care that they need. So certainly a number of barriers, but I really appreciate this group being together and some of the discussion that has probably already occurred and will occur throughout the meeting to really try to address those barriers. So thank you again, appreciate it.
Thanks so much, Dr. Stein. I think you really encapsulated much of what we've heard often in some of our work. We talk about line of sight, right, from screening to treatment. But even as you noted, that's not all that needs to be taken care of. And it's both on the care delivery and financing side of this journey and really putting the patient at the center. So, it's definitely been a tall task, but folks passionate like yourselves and others at this conference, I know, are working hard to overcome many of these barriers. Next, Dr. Cunham, can you tell us a little bit more about your psychiatric medical group and how it serves obstetricians and primary care more broadly? And how come we don't see more groups like yours across the country?
Yes, Chris, I'd be happy to. Our group, the model being collaborative, it's something that only very recently we are actually seeing the codes that doctors use to, bill for the services come out recently. And these codes are very new. And so it's something that's still a lot of doctors, I think, don't know about, even billers don't know about, or they're uncomfortable with, is this going to create a problem? with billing and rejections or denials from insurance companies, which holds up payments. So many different things that go into kind of running a practice and making sure that it's moving along and bills are being paid. And so I think one of the things that we're excited about is that we're trying to implement these codes, really get an understanding for it, feel comfortable with these collaborative codes, and kind of present it to the other people in the community, other clinics in the community. So reach out to obstetricians, reach out to even other primary care physicians that are not in our own practice, to really help them understand, that the codes, how they're working, how to bill for them, how to document for them. And so that's something that we're looking forward to doing, just to implement better integrated care. And I think, the one thing that also is, interesting is that some of these codes, it does take away some barriers, which is really exciting. For instance, like when Medicare reimburses for the collaborative code, if you are a patient in your primary care, you can maybe jump on a video appointment with a psychiatrist or a psychiatric nurse practitioner, and they don't have to necessarily be paneled on Medicare. So you're taking away all the little kind of roadblocks that might be there already, to make sure they're getting care from a board certified, clinician, or, somebody that is, able to give the care, but taking out the whole the messiness of, like, does insurance cover them? Do they take the same insurance, and this and that? And so that's something that I think will really be helpful and moving forward and making sure, like, the integration happens. And it's also, I think, important to know that I think one of the slides mentioned that, a lot of people don't end up going and seeing a psychiatrist, even if they have access to one, which is already difficult. And so kind of having that availability in the primary care clinic can be very helpful, because those are the people that we miss. Like, they never get to see the psychiatrist. And so they feel that they can trust their primary care, or they're in an urgent care setting where, they want to be able to get something done while they're in the urgent care. And we don't have to worry about the follow-up and how are they going to get to the doctor's appointment, and all the things that Dr. Zahn had mentioned earlier, and kind of takes out some of that. And I think it's just probably one of those things where it's difficult to really, do all the work that's required to organize, all the communication, when EHRs don't all communicate with each other that well. And, the notes are not easily seen between doctors. And also, we have to do releases, so that can this doctor primary care even give information to the psychiatrist? There's a lot of barriers there that could be maybe relieved when we kind of create more of an integrated model. I think other than that, I think the goal is to just be able to make urgent care, primary care obstetricians comfortable in initiating the screening, like Dr. Zahn said, and not worrying about what does that mean, what's the next step, because I've definitely heard that fear when I go and talk to them as well.
Excellent. And just for folks that may be not familiar, because I think the word collaborative sometimes could be used in the space in multiple ways. When you're talking about collaborative codes, you're specifically talking about the collaborative care model codes. And I know Joy put a link to them in the chat. But as the slide I had earlier, the spectrums and different methods that people are tackling this space, that is one of the most efficacious models that are out there. And definitely one of the ones that have been shown to have great impact in the specific space, but can sometimes be challenging depending on the practice settings that you have, and know that you all have some of those unique experiences, especially having those sister primary care organizations that allows for some of that coordination. Let's hear a little bit from you, Jennifer, because I know your all's experience is a little bit different and setup is a little bit different than what Dr. Cunham had mentioned. So why don't you tell everybody a little bit more about Unified Women's Healthcare and what you do in your specific role to support screening and integration more broadly within group.
Sure. So Unified Women's Healthcare is the diverse women's health company focused on creating a better healthcare experience for both patients and providers, along with all of our care staff. We are the largest physician practice management company dedicated to women's health, And throughout the entire organization, we support providers across nearly 900 locations in our country. In addition to the MSO services we provide, those are revenue cycle, finance, credentialing, human resources, but Unified also offers operational support and platforms to elevate efficiency across all our practices. And like I mentioned before, I work in the New York market called Square Care Medical Group, and I manage all the population health initiatives for our New York care centers. So that includes being a liaison between the provider and the patient to close any gaps in care that may arise from social determinants of health. And while social determinants of health cross wide spectrum of issue, it's a big issue today, I will be focusing on our mental health referrals, specifically with our OB population. With that being said, for my OB care management population, our providers are performing the depression screenings during their first OB appointment, as well as during the 6-week postpartum visit. The care management referral form will indicate a summary of what's going on with the patient and the provider's concerns. And while most of our referrals come back positive, I've had a few cases actually that were negative, but out of abundance of caution, the provider sends me the referral anyway, and I work through it with the provider and the patient just to make sure we're not missing anything, even if it is negative. Our providers have a conversation with their patient about the depression screening, and will inform the patient that I'll be reaching out to them, so we already have that connection. And after speaking to the patient and getting a better sense of what their needs are, I will help the patient get connected to appropriate resources. And once that connection has been made and the patient is stable, I discharge the patient from the care management program.
Excellent. Well, I think it's interesting hearing both you and Dr. Kunum talk a little bit about kind of some similarities and differences, right? And I think we'll have a little bit of chance to dive deeper into kind of understanding what those similarities and differences are. But before doing that, I think it would be really great to bring Blair, you into the conversation, especially representing purchasers, understanding the importance of financial alignment, and talked about that in my slide in terms of being able to actually move the needle forward in this specific space. So can you talk a little bit more about the kind of employer's perspective, their role in promoting and enabling integration?
Absolutely, and thanks for the opportunity. So, influencing maternal mental health outcomes really does require multi-stakeholder participation. But purchasers certainly play a large role here. So, thinking about all of the different stakeholders that you've got, you have policymakers who need to mandate standards for maternal mental health. Then you have purchasers who need to pay for value and only contract with providers who are meeting quality standards and or require or reward perinatal care with behavioral health integration. So, employing kind of a carrot and a stick there. Then you need to have payers or health plans rewarding value over volume, ensuring network adequacy of providers. And then you need to have maternity providers screen and refer to appropriate treatment in order to get to this end goal of birth participants receiving appropriate care for mental health needs. In the employer space, in terms of what can employers and purchasers do to, what strategies can work to promote maternal mental health, we've talked about a couple of different buckets, as it were. So in kind of the network design, we encourage employers to talk to their provider networks about mental health integration in maternal care and group maternal care strategies, things like centering, group lactation support classes, et cetera. Also ensuring that moms have choice in their care team, including access to midwives and birth centers. Monitoring health plan access standards and authorization processes and payment adequacy for mental health. And this is a big one, and I know one that's been highlighted a lot already in this conversation. And then also telehealth options that will help work better for families and for birth participants as individuals. The next kind of big bucket really falls into the consumer education piece. So employers can play a really large role in educating their members and beneficiaries on the importance of screening in the prenatal period, since we know that a lot of the sort of signs and symptoms and challenges that happen in the prenatal period are mirrored and often become more acute in the postpartum period. Secondly, highlighting local community and support resources. And third, providing education on the benefits of vaginal birth, knowing that, that is having to recover from a C-section can be a lot more difficult, both physically and mentally. And then also just some sort of additional support that purchasers can consider and should think about what they can do is how to provide flexible work options to allow time for additional appointments. And I think that is where, we now have a much different way of thinking about our work time, in this pandemic and post-pandemic world. And so allowing for that flexibility, I'm glad to say is, I think, coming to the forefront as something that purchasers can do to make sure that their employees are having that work-life balance and able to take time to do things that are good for their health. Also considering reviewing your family leave pay and policies, and then providing flexible coverage options. Things like doula care are really on the rise in terms of gaining kind of a public awareness right now. And those are some great strategies that employers, can consider. Covering those types of services can really help not only the individual birth participant, but also their families to prepare for the childbirth episode and to prepare for everything that happens afterward. So those are just a couple of things that we have been working on with our purchasers. And as I said at the beginning, it certainly is, it takes a lot of, it's a multi-stakeholder effort, but there is certainly a role that employers can play in this initiative.
Thanks, Blair. Yeah, I mean, I think you did a really great job of kind of touching on both the levers employers have, but just the general care experience, right, that the employees have, and it changes, right, depending on what their care status is and what their needs are, and the emphasis, right, of working across these stakeholder groups, be able to align them to create a seamless experience ultimately for those people that are navigating these often in times of crisis or concerns, and being able to do it in a timely way is really critical. That it truly feels integrated rather than feeling like you're a baton being passed between one system to another and the challenges associated with that. So Dr. Zahn, can you talk a little bit more about just the importance of that kind of seamless experience for patients and what you think some of the solutions can be to help enable that type of experiences for patients that are needing this type of care?
Well, thank you, Chris. I think, for the seamless experience, and ideally it's seamless for both the clinician and the patient, really involves coordination, the integration that has been described, a coordinated and aligned process that's easy to use. So it's a referral system that the clinician can easily get the patient into, and an easy way for the clinician to be able to get into that referral appointment. I think doing that requires education, and I think beneficially for both. The clinicians can certainly be educated about the system or about the resources that are available and how to use them. I know we're actually, in fact, it just launched, it went live today, sharing the University of Massachusetts Lifeline for Moms program, but it's a superb resource that has clinical guidance as well as other resources to be able to create a system and to help establish a system in a local or regional area. But it really requires education so that the clinicians know where to go. But I think it's also beneficial from a patient education standpoint. And we certainly recognize that patients can sometimes be their own best advocates. And if they're asking for help, even if the clinician isn't quite up to speed on the system or how it works, again, it helps to reinforce the patient-centered approach to this to really identify the issue for the patient and try to get them plugged into the system. So I think there's some real value to patient education to increase awareness of the issues and to also help normalize it. I mean, this is quite a common problem. We know that mental health is a problem nationwide, not just for our pregnant patients or postpartum patients. And I think COVID really shed some light on the challenges of mental health in this country. So I think to make it less of a stigma, less of an issue, that people should feel okay to ask for help if they feel like they need it, and it's okay for them to do that. I think, again, addressing the social and structural determinants are also the challenges that patients face, and be able to try to overcome those barriers. Things like telemedicine, telehealth can certainly help that. Even the example used before with the postpartum patient might have transportation insecurity and single mom and trying to manage children at home and then get themselves to an appointment. Imagine how much more efficient that could be if it could be done via telehealth, and you're bringing the behavioral health consult to the patient at home as opposed to making them get to an appointment. Really has the capability, I think, of expanding what we can do. There are certainly benefits during the COVID pandemic as far as relaxing some of the restrictions on the use of telehealth. I think we all have a reasonable concern that some of those might get reversed, and I think we all hope that they don't, that we continue to take advantage of the expanses in telemedicine that we experienced. And I think the other aspect are, some of the things like the perinatal psychiatry access programs that already exist in a number of states and are continuing to expand. Those are examples of systems to help provide that ability to coordinate care and get patients plugged into the system. And the bottom line is we just need to make it less scary. We need to make it more part of normal practice to be able to screen and get patients plugged in. We do it for all sorts of other things in pregnancy and the postpartum period. We screen, we check blood pressure to look for hypertensive disease in pregnancy. We screen for diabetes. We should be able to screen and get patients seen for mental health as well. It should be part of the normal practice that's built into care for all pregnant and postpartum patients. So thank you very much, Chris.
Absolutely. I think that is a great encapsulation. I think I probably should have done this in my slides, but a mini plug. We have a webinar coming out that talks specifically about the resource you just mentioned that ACOG is releasing, and with the MCMAP programs, it talks a little bit more specific. So be on the lookout for that. It provides a really great example of how this can work in real world settings. Speaking of which, I think it'd be really great to kind of circle back with both Jennifer and Dr. Cunham and talk a little bit more about kind of that experience that Dr. Zahn talked about being seamless for both the providers as well as the patients, and just provide a little bit more detail about kind of how the process works for you all, especially Jennifer, for you as you're trying to connect folks from the obstetric side of things to mental health providers, and what does not work in terms of that kind of feedback mechanism once they're able to get some of that mental health support, and how that works on the obstetric side of things. So Jennifer, if you wouldn't mind starting first, and then Dr. Cunham will circle back with you and hear a little bit more about how it works for your all's model. Jennifer?
Sure. So after I complete my initial assessment on the patient, resources have been provided to her. And I will follow up with the patient again to make sure she's connected to the appropriate resources for her care. During my follow-up call with the patient, I will inquire whether she is comfortable with the mental health professional she's working with, and if she feels the resource is helpful. After that relationship between the patient and the mental health professional is established, I discharge the patient because the patient and the mental health professional are working on their own goals together. And for the OBGYN, they receive updates on patient care when I speak with the patient during our follow-up call. The OB is fully updated on all the work I do, especially through the EMR documentation. In addition, all the providers know they can reach out to me either by phone or by email or email at any time to discuss the patient's case in further detail. But clearly, transparency is the key in order to give our patients comprehensive care.
Excellent. And Dr. Cunham, how does it work for you all with the collaborative care model, and how does that kind of work similarly to what Jennifer just described, but perhaps a little bit differently given the different dynamic and structure of how your models developed?
Yeah, so, because we function, as a psychiatric clinic, but then also as a collaborative clinic, we kind of, can see both sides of it, where we are working with our sister organization, and that's definitely a lot easier. Physically they're next door when we're trying to get releases signed for open communication between the psychiatrist and the primary care physician. That's a lot easier to be in that way. But then when we're doing it in a more traditional fashion, where we're reaching out to other primary care obstetrician at different clinics, there can be some difficulty at times, just because there could sometimes only be one-way communication. If the patient signed a release with their obstetrician to give us info, but they don't sign a release necessarily or feel comfortable with us actually giving information back to the obstetrician. It happens sometimes. And then also the other maybe issue at times can just be that it's difficult we don't always have someone like Jennifer at every single private clinic out there. So it would be wonderful if we had 1,000 Jennifers out there. I think that's definitely a good solution to have. But it's just something that, now that those collaborative codes are out there, that makes it so a little easier to implement. There's some financial, support to be able to hire someone like Jennifer to be able to be the in-between, which we didn't have, for a long time before. So I think that's something that is kind of great to see, and we're able to use in our integrative model, but also even when, communicating with other clinics or health systems.
I think part of our previous discussions, you all have the ability of sharing one EHR, which can help with that communication. I believe, Jennifer, for you all, it's different systems, which I think shows, some of the challenges when you're having to navigate multiple systems, and when you're able to avoid those issues, how that can really support greater coordination. But again, the challenge is you can't really have one system across the country. And so that's just kind of the nature of much of how this care is being facilitated in many practices across the country.
I would say too, to piggyback off that, going back to care management, once the patient's working with the mental health resource, the notes from the mental health provider are rarely shared back with the OBGYN. If the provider feels it's necessary to obtain documentation from the therapist or psychiatrist or whoever it may be, a request is usually made to the patient, so we obtain a HIPAA release. But in my experience, it's not common these requests are made.
Yeah, that's something we've heard time and time again, both using HIPAA as well as Part 2 as reasons not to facilitate and share care coordination. And from our experiences and understanding of those requirements, often there are overly interpreted to create additional barriers that is really unnecessary, that there's a lot more care that is covered by both HIPAA. Part 2 is very specific to types of care dynamics. So again, on the collaborative, we have some resources too that talk about both privacy and security issues that constantly come up in this space, and really how do we make it easier to do the right thing in this space. So I'm really appreciative that you all brought that up. So I want to make sure to bring Dr. Wildenhouse into the conversation. We've talked a little bit about, the kind of traditional screen to treat, but it's also really important to be thinking about both upstream and predictability when it comes to particularly maternal mental health disorders, and the importance of getting women earlier timely support, which is a key part of the integrative models we've been talking about. So Dr. Wildenhouse, can you tell us a little bit more about your work at Johnson & Johnson to address this specific issue?
Yeah, sure, Chris. As I mentioned, I'm part of a group that is trying to move from a diagnose and treat model of disease care to a predict and preempt model of what we call true healthcare. And I was given the task to look at postpartum depression to see if it fit as to one of those disease states that we could get in front of. I scoured the literature because I had just a cursory knowledge of postpartum depression. And when I came away from it, I realized several important things and developed 3 hypotheses that I wanted to test. The first one is that I thought that it's a misnomer to call it postpartum depression, because my guess was that a lot of the depression starts in the antenatal period, so perinatal depression might be more of an encompassing term. The second prediction was that this is not just a singular condition. This is a heterogeneous syndrome. And I believed that there were subtypes of perinatal depression that have different causes or different etiologies. So we wanted to then test could we see different symptom patterns emerge with the type of perinatal depression? And was that depression coming on at different phases of the pregnancy or postpartum? Were those three things together, the etiology, the symptom profile, and the time of onset, might help us to understand those clusters or those distinct subtypes? And then the third hypothesis is that we could develop very effective, simple screening tools that would allow us very early in the pregnancy to assess and predict which women would be at highest risk for future maternal mental health issues, whether that's anxiety, depression, or some other related conditions.
Fantastic. And I know that you've also done some research specifically around developing predictive models. Can you tell us a little bit more about those efforts as well?
Sure. So one of the studies that we did is we partnered with babycenter.com, and we put a questionnaire out for people to participate in a prospective cohort design, which is basically just you sign up and online, you will get surveys or assessments at periodic points throughout the pregnancy and postpartum. We'd like to learn more about maternal mental health and well-being. So within a couple of weeks, we got almost 900 subjects to enroll in the study, and which was phenomenal. And we also got them very early in the pregnancy. So these women were between 4 and 10 weeks pregnant. They had just done their EPT test. They hadn't even gone to see their OBGYN or family practitioner yet. And we gave them a series of questionnaires that we repeated in the first, second, and third trimester. And then again, 4 weeks postpartum and 12 weeks postpartum. And the objective was to see who developed depression, when did they develop the depression, and from a baseline assessment using validated psychometric tools, could we develop a very simple, brief screening questionnaire that would not identify women who were already depressed? We have good models for that, but could actually predict who's at high risk for getting depressed at some point in either the antenatal or postpartum period. So we followed these women longitudinally, and what we did find is that 80% of the cases showed evidence of onset during the antenatal period. They may not have had full-blown depression where they were aware of it or others became aware of it until after the baby was born, but you could see the patterns emerging early in the pregnancy. There were differences based on whether they got depressed in the first, second, or third trimester. There were differences between whether they got depressed in the first 4 weeks of postpartum or they had a delayed onset where they got depressed maybe more in weeks 5 through 12, for example. So what we were able to do is to take through predictive modeling, we were able to identify 21 items out of a baseline that had 180 items in it. And very simply, with using your smartphone, using an iPad at the clinic, having women complete this quick questionnaire, which will take them a couple of minutes, you can very effectively start to triage out of a full panel of pregnant women, the ones that need more intense following, monitoring, and potentially intervention, again with the goal, can we prevent the depression from ever happening? Or at the very least, can we mitigate it in the sense that it either delays the onset and or makes it less severe along the way? So with these 21 items, we were able to, just as a first pass study, we were able to use a predictive capability where the area under the curve, for example, to predict a third trimester onset was about 0.75, and a postpartum onset, which is now 9 to 12 months later, at about 0.72 area under the curve. So this, as a first pass, we became very excited that through very simple economical screening tools, we can identify that risk pool. We can then help triage into the appropriate care. And then along the way, can we learn of these subtypes so we know not just that there's one way to treat the condition, but by understanding the underlying causal factors, we can be more effective in that process.
That's super exciting. It's really intriguing options and a different kind of model, right, to be able to move from just diagnostic to treatment, prevention. And I think, some of what we've heard today is, having systems in place that facilitate that, because it can be challenging, right? If you're preventing something into the future, how do you ensure that the value is being distributed across the various different stakeholder groups that are involved, and that recognition of the value that's being brought to bear is supported so it can be sustained over a long period of time, because that's what we ultimately want to do, is prevent where possible, mitigate where necessary. Our system, unfortunately, or systems rather, aren't necessarily always set up to be able to fully take advantage of that kind of dynamic. So I think that's where really excited for all the work that you all are doing, and those folks that have joined us today are working to really tackle these issues and make that a reality. So I appreciate you sharing your experiences there. So I know we're starting to wind down on time, but wanted to just circle back with everybody and get some final thoughts, especially around what may give you hope around screening and integration more broadly within primary care, and any other kind of key thoughts that you would like to leave everybody in terms of your experiences in the specific space. So I am going to go in reverse order from introduction. So I'm going to circle back to you, Dr. Wildenhouse, if you wouldn't mind providing kind of any last thoughts you have to share with everybody.
Yeah, I think that we came away from the 3 hypotheses with strong support on all of them. We did a series of studies, one with Samantha Meltzer-Brody at the University of North Carolina as part of the PAT consortium. We analyzed thousands of EPDS scores across the world. So we see some evidence that there's generalizability to what we're doing. And we're really excited to think that if we can start to uncover these subtypes by understanding not only the symptom profiles, but when they begin to onset, we can become much more effective with our treatment. We can frankly do more of it through telehealth, through digital technology, through groups, and therefore we can address the crisis that we have in terms of not having enough providers and enough trained providers to be able to do that mitigation. So we're really bullish on where we can go with this and really excited to be part of this conference.
Fantastic. Dr. Cunham.
Yeah, so I am very passionate about this topic and maternal mental health. And so I'm very excited to see, the spotlight on maternal mental health, which, has really been, not recognized for a very long time, especially when it's difficult to conduct studies and gather data, with this population. So I'm really excited to see the interest and to see the things that we can do and to really break down the stigma of it so that, women and mothers and families feel comfortable supporting their moms to reach out for care, and really being able to find the care in multiple ways now, whether it's telehealth or through primary care, through their obstetrician. So I'm very excited to really open those doors for them. And I'm looking forward to really seeing, in these next few years, what we can discover and really be able to implement new treatments and give the care that we need.
Excellent. Dr. Zong.
Thank you. I think everything that Dr. Cunham and Dr. Wildenhouse had said, I think the fact that it's getting the attention and the spotlight that it's getting is critical, because nothing would happen without that. And we certainly see nationwide or worldwide for that matter, there is a growing attention to this really important matter. I think the fact that some of the systems are growing, we certainly have a lot of work to do, but there are some in place and there's continuing work to grow them, to get patients plugged into the systems that they need is really exciting. The prevention capabilities, that's an incredible advance. I think if we can really get to a point where we can clearly identify someone earlier in their pregnancy who is at risk, and then we've got an intervention that can help as either prevent or mitigate, that's the best we can hope for. So I'm really excited to see the prevention work continue. So again, thanks everyone for your attention today.
Excellent. Jennifer?
So, screening patients and integrating the care management program as part of the patient's care really makes a huge difference in the quality of life for our patient population. And so many patients I work with previously have fallen through the gaps in healthcare system, and they did not have the vital life-saving resources that we have now. For me as their care manager, it's amazing to watch a transformation of a patient that first came in, was struggling with their mental health, but then received the care that they needed and ultimately found ways to get well and work through it with their mental health professional. And clearly, as we all discussed, screening for maternal mental health impacts everyone.
Excellent. Blair.
Thanks so much. Well, I really appreciate being on this panel, and I want to thank 2020 Mom for gathering us all together, because it does take a lot of different voices from a lot of different organizations to get this work done. And and I also just realized that my background is flipped, but I think that is actually a little bit of a nod to what the folks in this forum are trying to do. We're trying to flip the paradigm on mental health and on what it means for moms and families. And you know, it's gone from being a taboo subject to being something that people are able to talk about openly, which is great. We've gone from thinking about, well, we're not going to worry about paying for that at all, to, well, what's the best way to pay for it? Do we have a value-based care structure where it's all bundled? Do we parse it out and pay for it individually? Frankly, I think both can work. And we have a whole different way of thinking about how providers can work together to address these challenges. You know, we've talked a lot about behavioral health integration in the primary care and in the maternity care spaces. You know, at the end of the day, we're just trying to get moms to be able to access the appropriate level of care and the appropriate provider. So I'm encouraged by the fact that we're seeing really a proliferation of how to do that, and a lot of energy around, you know, what that can look like, what the care delivery looks like, what the payment looks like, all in pursuit of this better experience for moms and their families.
Fantastic. Well, I just want to thank you all so much again for taking time out of your busy schedules to talk to everybody today. It's just been a fantastic discussion, and I've even, you know, continued to learn quite a bit. And I think, Blair, you've mentioned it before, and others, I think just the recognition across the system of the importance of this topic and working together, and the fact that much of this work is happening now, and it's about spreading these efforts across the country, and that it's possible to do it. I think is something that is not necessarily always the case when we're talking about quote unquote innovations within the healthcare system. And I think those folks around this table, those folks joining us virtually, and others that are just so passionate about this topic area, and ultimately the patients that are just desperately wanting this type of support. I think that now is the time to be able to really bring this to the forefront. And I think there's a lot of great solutions and opportunities to be able to move forward in a way that really has the type of impact and creates the environment that we're all looking to see. So I know we're a few minutes early, so hopefully it doesn't throw everything too much off for Joy and the rest of the team, but just really want to thank you all again for all this great discussion, and just really thankful to be able to have the AMA, the members of the collaborative, and everybody else part of this conversation. So with that, I will pass things back to you, Joy.
Thank you so much. Thank you, Chris. What a great panel. We appreciate you all so much. And Blair, I think, as you said, it really does take multiple voices to solve this problem. And you are all those voices. We're so glad that you could be with us today. And Blair, I have to comment on the reversed image on your screen. Interestingly, what we see is that it's not reversed. So I think that's sort of a nod to just how confusing, right? Sometimes our perspectives can be so different depending on what seat you sit in when you're in the maternal mental health space. So yes, thank you, Blair. Excellent. Appreciate you all so much. And now what we're going to do is take some time to put up our Poll Everywhere poll. We want to hear from you, audience. We have 300 of you watching live right now. Go to pollev.com/2020mom. And please drop in the word or the phrase that resonated most with you during this session. How are you feeling? What are you thinking? If you use a phrase, make sure you use an underscore when you drop that phrase in. And we'll go ahead and take just a moment and pop up that slide here in just a moment. Excellent. Hopeful and excited after hearing this group of dedicated professionals, knowing that the American Medical Association's leading a wonderful charge here gives me much hope as well. Coordination. And group therapy is interesting, just to think about how can we scale solutions quickly and get women together in groups. Paradigm shifts, prevention from J&J. There's also some really incredible work coming out of J&J, and I think other researchers outside of J&J are also looking at novel ways to detect depression or anxiety or other maternal mental health disorders outside of a screening practice. So a swab or a blood test. So exciting to hear about those potential solutions coming down the road in the pike as well. And coordination. It's very fitting to see coordination in the center of this slide.